गुड इव्हनिंग एव्हरीवन. डॉक्टर वृषाली आहे. डॉक्टर वृषाली पारधे जॉईन केलंय. डॉक्टर अजय ओवळ सर आहेत का?
येस मॅम आहे.
ओके सर. डॉक्टर संतोष रानडे.
येस मॅडम, प्रेझेंट.
येस सर. डॉक्टर रोहन देशपांडे. ओके, एक 2 मिनिटात आपण सुरू करूयात. हे दोन आपले कॅन्डिडेट जॉईन झाले की आपण लगेच सुरू करूयात.
आणि असलं नावाचं ते असलं नावाचं
दाखव 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 बरं, एवढं काय. सोड की. तसं नको. इकडे दाब. तसं सोड की. तसं सोड की. माझ्यात.
कॉम्प्युटर डिपार्टमेंट. जे बाकी
सोड की. अरे तिथं एकदा टच सोड.
डॉक्टर वृषाली.
Yes, ma'am.
Okay. So, good evening all. I am Dr. Carly Gitanjali on behalf of Maharashtra University of Health Sciences, Nashik. I welcome you all for online clinics. And today's topic is last topic in the series of dermatological disorder, and the topic is eczema. So, to discuss this topic, we have Dr. Vrushali Pardhe. She is second year PG scholar from Tilak Ayurved College, Pune. And then we have expert panel, Dr. Ajay Uwar, Professor and Head of Department of Dermatology from Vilas Rao Deshmukh Government Medical College, Latur. And our second expert is Dr. Santosh Ranade. He is Associate Professor from Department of Physiology, SJEP's Homeopathic Medical College, Kolhapur. And our third expert is from Ayurveda, Dr. Rohan Deshpande, Associate Professor, Department of Agatantra, Tilak Ayurved College, Pune. So this is our expert panel for today's discussion. And let's start with the presentation by Dr. Vrushali. So Vrushali, you can share your screen.
Yes, ma'am. Hello, am audible, ma'am?
Yes, you are audible, but
Okay, okay,
your screen is also visible. You may start.
okay, okay. Good afternoon, all. I am Dr. Rushali Anil Padre from Tilak Ayurved Mahavidyalaya, Pune, presenting under the guidance of Dr. Rohan Deshpande, Department of Pagatantra Evam Vidhi Vaidika. Today's my topic is eczema and vichachika, a correlative case presentation bridging modern dermatology and Ayurvedic Nidana. This case bridges modern dermatology and Ayurveda to analyze chronic eczema. We will match its clinical presentation to the classical Ayurvedic condition, that is vichachika. Using this framework correlation, we will establish a diagnosis. Uh, Before we move to the case presentation, I would like to briefly cover some terminology related to eczema and vichachika, which will make the case easier to understand. First, we have dermatosis, that is broadest term, which include any cutaneous disease that is inflammatory, neoplastic, or congenital. Second is dermatitis, a family of inflammatory skin disorders, acute and chronic. And third is eczema. Hello, hello.
Dr. Arjun, please mute yourself. You are disturbing all. Please.
Yeah, then we can continue. The third is eczema, a genus of inflammatory dermatitis, which includes atopic, nummular, and other named species. Uh, Here we can see the eczema has five morphological stages. The first one is erythema and swelling, which includes initial acute inflammatory change. And second is oozing and vesiculation, that is fluid-filled lesions and weeping. Third stage is crusting and scaling, that is surface debris as fluid dries. Fourth stage is lichenification, which is thickening from repeated scratching. And fifth is hyper or hypopigmentation, which caused due to melanocyte effect of chronic inflammation. Here we can see the acute stages include stage 1, stage 2, and stage 3. And chronic eczema includes stage 4 and stage 5, appearing only after weeks of persistence. Uh, we can see the eczema and its clinical classification. Uh, First one is acute contact dermatitis. Second is atopic dermatitis, seborrheic dermatitis. Who are the infantile eczema and eczema of hands and feet. That is plantar eczema or palmar eczema. Briefly, I'm going to discuss about vichachika, the Ayurvedic perspective, which we are going to correlate with eczema. The vichachika classified under Shudra Kushta. The cardinal features, we can see the similarity in the cardinal feature of vichachika with eczema. That is kandu is equal to, we can say, itching. Strava is a discharge and oozing. Pidika, that is eruption. Vaivarnya is discoloration. And raji, that is linear hyperpigmented streaking. The dosha involvement in the vichachika is the three doshaja, that is vata, pitta, and a kapha. With vata and kapha most implicated in chronic thickened lesions. Aggravating factors of that vichachika is cold winter exposures that aggravates vata and kapha, spicy and sour food, viruddhahara, and repeated skin irritation due to use of cosmetics. Modern Ayurvedic correlation, we can see the similarity shown in two tables. That is, for in first one we can see eczema, and second one is vichachika, which is Ayurvedic. Here we can see erythema and swelling, that is stage 1, and in vichachika also we can correlate with early vaivarnya due to pitta and kapha activation. Then oozing and vesiculation in stage 2, that correlate with SAVA, thrusting and scaling in stage 3, which relate to pitica, and itching present at all stages. Which we can correlate with Kandu, that is cardinal symptoms seen in all types of pushta. Lichenification stage 4, which can correlate with chronic kapha vata, hyper and hypopigmentation, that is stage 5. Vaivarnya, that is chronic, and Raji is speaking. Next, lastly, now we can discuss the patients which describe the all eczema symptoms. The patient we have 42 years male, 68 kg by weight, and 120 and 80 BP. That is general examination. Chip complaints, he came with chip complaints, that is itching, thickened discolored patches over both legs, mild oozing, that is strava, and occasional burning sensation. He presented case history of chronic onset, 4-year duration, aggravated by his condition in winter, that is due to vata kapha nidana. Then again aggravated by sore as spicy food. No diabetes or hypertension is seen in patient. Past medical history, he used topical steroid cream that which gives him only temporary relief only. Here we can see the hello.
Hello.
Hello. Is there any problem, ma'am?
No. Please continue.
Okay. Then here we have pictures of the patient, which here in picture we can see the hyperpigmented thickened dry lesions of eczema. We have done a physical examination of patient to rule out the disease. First is skin, which shows hyperpigmented thickened dry lesions or bilateral legs with scratch marks. No active oozing or infection seen. On nails, there is no any type of signs are seen. Here, hair showed normal distribution and general condition of patient was moderately nourished. No pallor or edema were seen. Differential diagnosis. Hello.
Hॅलो हे जे मध्ये बोलतायत ना त्यांना प्लीज म्यूट करा, त्यांचा डिस्टर्ब होतोय. SATS. Yes.
Now can I continue, ma'am?
Yeah. Please, Vrishali, you may continue.
Yeah. Differential diagnosis. 4 differentials were systematically excluded. That is the DRU. The DRU is correlated with, in modern terminology, tinea corporis. No well-defined spreading and ring-like margins were seen. Vipatica, that is palmar plantar eczema. Lesion size was leg, not palm and soles, so it excluded. Pama, that is scabbing, no nocturnal itching or interdigital tracts were marked. Then we have psoriasis-like lesions, no silvery scaling, nails were normal, seen in the patient. Then we have final Vichatika, that is correlated with eczema. Here we can see the infection undo itching, Strava, that is oozing, Strava Varna, that is hyperpigmentation and lichenification of the skin. Then we have final diagnosis, clinical correlation. The final diagnosis rests on clinical correlation of 4-year chronic course with winter and so spicy food aggravation. The cardinal features of Kandu, that is itching, Strava, oozing by history, and Vaivarnya on examination, that is lichenification and we can say hyperpigmentation of skin. A site, morphology, and course consistent with all four differentials, and no systematic disease honesty is seen. Final diagnosis is Vichurtica, that is an eczematous lesions with itching, oozing, and wyvernum. That is discoloration, corresponding to prodic stage 4 to 5 eczema in modern stage. Then clinical discussion. Bringing it together, the four-year chronicity places him in the lichenified, dyspigmented stage, that is hyperpigmentation, not acute disease. The absence of active oozing on exam means he is past the Strava dominant phase, that is oozing phase. Winter and sore spicy aggravation map precisely onto the Vata Kapha and Pitta Kapha Nidana, that is for Vichatika. And the fact that steroids gave only temporary relief is predicted by the board system. The suppressed inflammation without correcting the underlying chronic cause, dosha imbalance or reversing established lichenification. The general management and principles we can suggest for the treatment of eczema, that is in Ayurvedic management. First is Nidana Parivarjana, that is avoid cold exposure and sore and spicy food. Shodhan Chikitsa, that is detoxification to address underlying dosha in imbalance. Shamana Chikitsa, internal and local medication. Aim of the this is to address chronicity at the dosha's root, not just suppress the lesions.
So
Hello.
thank you so much, Krushali. You have presented detailed case of
Thank
eczema.
you.
Thank you so much. Please stay with
Thank
us.
you.
Now to discuss this case, etiology or pathophysiology, investigation, treatment, and limitations. We will call first Dr. Ajay Over. Dr. Ajay Over, sir.
Yes, ma'am.
Sir
I am
is
sharing the
professor.
presentation.
Again, I will like to introduce Dr. Ajay Over, professor and head of Department of Dermatology from Vilasrao Deshmukh Medical College, Government Medical College, Latur.
Uh-huh.
Yes, sir. Your slides are visible, sir.
Yes, ma'am. So first of all, congratulations, Roshali, for a nice presentation. Here I am here to give perspective, this modern medicine perspective on eczema and atopic dermatitis. So why this is important? Because the patients who are suffering, they present to us with a rash, and we often diagnose it as eczema. Around 15 to 30% patients are children, and 2 to 10% are adults. So, how to identify these children? 60% of they develop this condition in first year of life, and understanding this is important because the children who suffer eczema or atopic dermatitis in first year of life, they may progress to allergic rhinitis or asthma. Approximately 50% of patients, they develop asthma and 75% develop allergic rhinitis. Eczema by literally by word, it means to boil over. In Greek, it is called eczema. So it is an inflammatory dermatosis characterized histologically by spongiosis with superficial perivascular lymphocytic infiltrate. So as we are trying to correlate this with uh, our ancient medicine, um, here knowing the terminology is important. Many a times I feel that why this condition is happening or what is the cause of the disease. So here in figure you can see the epidermis. On your left is healthy skin, where you can see different corneocytes or the cells which form stratum corneum or epidermis, which is our outermost layer. The cells are arranged like bricks one over other. So in left side we have healthy skin, whereas on right side what happens is the structure of bricks is damaged. So it causes transepidermal water loss, means the barrier naturally nature has provided us with lipid bilayer, and due to decrease in ceramide, that is decrease in lipids in this epidermis,
Department, please read. नितेश सर, तुम्ही आहात का?
हाँ आई एम हियर मैम.
हा प्लीज प्लीज त्यांना म्यूट कर.
हाँ. So basic cause is what individuals they are susceptible. They have filaggrin mutation. The filaggrin gene prevents creation of normal flat cornocyte, resulting in haphazard skin cell organization. So it also causes deficiency of lipids, which fail to hold the cellular bricks together, comprising structural integrity. So another important part is there is reduced beta defensin. Beta defensin is a substance which helps our body naturally to prevent microbial colonization, like they prevent aggregation of Staphylococcus aureus or viruses. So understanding this basic pathophysiology regarding barrier defect and breach in barrier defect is important. So what happens that this condition is it causes intense pruritus. We call it itch and scratch cycle. So starting point of the patient distress, we might feel that the condition is causing itching, but here we have to understand that itching it activates mechanical damage. The mechanical damage to the barrier is due to physical scratching, and which exacerbates the existing barrier defect. So what happens? This damage in the barrier, it allows different types of irritants and antigens and microbes. They get entry deep into the layer, and they again cause immune dysregulation. So this is these are the different inflammatory mediators like cytokines. We call it cytokines: interleukin 4, interleukin 13, and interleukin 31. So this is a Th2 immune pathway due to which this disease occurs. So these inflammatory mediators, they again cause intense pruritus, and this circle keeps on repeating itself. So loop is formed. So breaking this cycle is absolute cornerstone of therapeutic intervention. And if untreated, the loop inevitably leads to chronic skin thickening. We call it lichenification. So what happens whenever there is exposure of some allergen to the skin? So there are Langerhans cells in the skin. So any foreign material, it is came in surveillance of Langerhans cells. These Langerhans cells capture um, uh, that substance, and they present to the lymph nodes where there are T cells. So due to that foreign material, body initiates immune response, and body sends these inflammatory mediators, due to which there is redness, we call it erythema, there is oozing of fluid, there is edema, and it presents in the form of papules and vesicles. Due to fluid accumulation, vesicles are formed, and due to that edema, there is active oozing. So as student already has mentioned that there are stages here, mentioning this slide is important because we should know what is the cause of acute eczema. So in acute stage, there is a lot of inflammation.
आ रही है
So there is erythema, edema, papulovesicles, and oozing. When this happens for some time around 1 week, this acute stage subsides. The accumulated fluid it oozes out, erythema lessens, and this oozing it is followed by crusting. When it dries, it forms the honey-colored crust, and due to the abrasions or breach in the epidermis, there is fissuring, and after that
मेजर मेजर आर्टरी फटी होगी फिर मतलब उस हिसाब से
this stage progresses to further stage where
ओ हो
skin
हो
thinks
हो हो
that
हो
skin thinks that
हो
it has to provide a stronger armor to the skin, so the skin starts becoming lichenified, or
अरे
you can compare it with the bark of the tree. So that is chronic stage, which is characterized by dryness, explorations,
तब भी नहीं बढ़ रहा है
fissuring,
हाँ
lichenification. Lichenification means thickening and hyperpigmentation. So there are increased markings of skin over
1% भी
that
ऐसी सेंचुरी हुई के
region.
अंदर कुछ हुआ होगा ऐसा मतलब किसी को नहीं भनक लग पाई ऐसी
So
yourself,
हाँ
you are disturbing all.
हाँ हाँ सर
so
हाँ
Deepak
हाँ
Mukherjee.
at so here eczema,
हमें भी
as
ऐसे
we
फील
call
हुआ
it,
था
eczema is not a disease itself, but it is a pattern of reaction. So
अरे
we
बाप
saw
रे।
this earlier slide where there
हाँ
is acute, subacute, and chronic
हम्म
presentation. This is due to the exogenous causes, means the causes which are
हम्म,
outside our body, like contact dermatitis. The substances like nickel,
हाँ
which is present in artificial jewelry, cement, like
हाँ
potassium chromate. These
हाँ
these allergens are present in like
अरे
leather, even the Parthenium dermatitis. This is due to the external causes or exogenous. So when it is endogenous, we call it atopic dermatitis. Here you can see
अच्छा
erythematous lesion over this infant's face.
हम्म वो क्लॉट हो
When
गई
in
होगी बिल्कुल बिल्कुल हाँ हाँ
when there is infant,
बाहर है हाँ
there is typical involvement of the face of the
दोबारा
baby's
हो
skull.
सकता है ओके
Dennis, त्यांना रिमूव्ह करा प्लीज. हे दीपक कोटा जे आहेत त्यांना रिमूव्ह करा मीटिंग मधनं. एक अजून कोणीतरी आहे रोहित जाधव, ज्यांना कोणाला प्रॉब्लेम आहे त्यांनी
अच्छा
प्लीज
इसीलिए
अटेंड.
मैंने देखा आपने सुबह 4:30 4:15 के आसपास मेडिकल स्पेशलिस्ट ऑन कॉल का मैसेज डाला था ग्रुप में आपने
हॅलो.
ओ ओ
अरे धेंडे सर, तुम्ही आहात ना मीटिंग मध्ये, कम्प्युटर डिपार्टमेंट.
हम्म हाँ वो तो करते नहीं है वो तो पता ही है हाँ नॉन एंटरटेनमेंट में लिया होगा फिर सिक्योरिटी डिपॉजिट लिया होगा 10,000 रुपए वाला इन्होंने हाँ नहीं करते हैं वो हाँ
त्यांना म्यूट करता येतात.
तो आईसीयू में नहीं करते हैं ये लोग हाँ
सब करतात.
हाँ मैम. So this atopic dermatitis,
हाँ
as it starts before 1 year of life, generally 2 months to 2 years, the areas of
अरे
involvement are specific, like
अरे
cheek, scalp, and extensor aspect of upper extremity and lower extremity. So why this face is involved? Because this infant cannot move
कर रहा है
much.
समझ गया हाँ वो फव्वारा निकलता रहता है जो पूरा टाइम बिल्कुल हाँ 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 हाँ
मला आमचा आवाज येतोय का?
अरे बाप रे ओ तो उसी ने
Hello.
पकड़ा बैठ के पीछे हाँ
हाँ मॅम डिस्टर्ब होतोय त्यांचा मध्ये मध्ये.
करत नाहीये.
So
हम्म, हम्म,
why
हम्म,
this face?
थांबूयात आपण, मी त्यांची व्यवस्था करते.
हाँ 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 अरे बाप रे। नहीं, ऑब्वियसली हाँ, और क्या, वो तो कहना ही पड़ेगा। अभी फिर क्या बोला उन्होंने?
आपण सगळे रिस्पेक्टेबल फॅकल्टी मेंबर्स आहात, स्टुडंट्स आहात आणि इथे ही मीटिंग अटेंड करायला कुणालाच कंपल्सरी नाहीये. त्याच्यामुळे ज्यांना खरंच करायचे
ओके,
आहे त्यांना प्लीज डिस्टर्ब करू नका. हे दीपक मोठा ज्यांच्या कोणाच्या
कर दिया।
ओळखीचे आहेत त्यांनी
हाँ,
प्लीज त्यांना माझा निरोप कन्वे करा. आम्ही तर शोध लावूच ते कुठले आहेत काय आहेत, पण सध्या जर कुणाचे ते ओळखीचे असतील तर त्यांना प्लीज कन्वे करा.
जैसे हम भगवान के हाथ में है।
आमचं कम्प्युटर डिपार्टमेंट पण हेल्पलेस आहे.
मैम कंटिन्यू करूँ?
जैसे हम लोग बोलते हैं यूजुअली पेशेंट की फैमिली को, भाई भगवान के ऊपर दुआ करो। अब हमने अपना कर दिया जितना हम करते थे। समझ रहा हूँ। हम्म।
मैम
अरे
कंटिन्यू
बाप
करू
रे।
तर त्यांना जेव्हा समजेल तेव्हा समजेल आपण आपली कंटिन्यू. So continuing here, why these cheeks are involved? Because the infant bed is contact
ब्लड ग्रुप
mostly
कौन?
in contact with cheek and the exterior aspect.
अरे बाप रे।
Even the saliva drools for
किसी का नहीं है
the,
क्या? अपने बैच में किसी
that's
का नहीं
why
है क्या
this
टीचर?
skin is commonly involved. So in childhood phase, like 2 to 12 years, the lesions they occupy the folds like the cubital fossa, axillae, groins. So the distribution shifts toward the flexible folds, neck, wrist, and ankles. What happens in adults?
सर
More
आप करना
adult means
यार,
more than 12 years of age.
कहाँ से भी।
The chronic presentation is in flexural area.
मैं समझ
There
रहा हूँ,
will
मैं
be
समझ रहा
trunk,
हूँ। एक बार
there
शाम में
will
जब
be
भी आप
development
बहुत
and
जल्द
persistent hand eczema.
करने के लिए
So the generalized lesions
रिक्वेस्ट
they
करो।
try to limit to the lesser area
कुछ सर,
when
कुछ और चाहिए
patient
प्लीज, बेझिझक होकर आप
becomes
फोन कर
adult.
दीजिएगा सर, आई बी देयर, कोई दिक्कत नहीं है। मैं 10 मिनट दूर रहता हूँ, बट मैं आ जाऊंगा अगर कुछ भी रिक्वायर्ड होगा तो बता दीजिएगा सर।
कम्प्युटर
So
घर
the
घर पे
तुम्हाला जर समजलं असेल तर
बच्चे
मला
वगैरह
ऍक्सेस द्या, मी
वो
त्यांना रिमूव्ह करते. कम्प्युटर डिपार्टमेंट, इट इज हम्बल रिक्वेस्ट टू यू, प्लीज गिव मी ऍक्सेस, मेक मी को होस्ट, आई विल
मैम
रिमूव.
मैम ठीक है, थोड़ा मतलब वो ज्यादा स्ट्रेस आउट
दीपक मोठा
होंगी
म्हणून
बैठ के
आहे,
इस समय।
त्यांना रिमूव्ह करून टाका मीटिंग मधनं.
आपको कुछ भी हो सर, प्लीज बेझिझक होकर आप घंटी मार दीजिएगा। घंटी बेझिझक मार दीजिएगा। मेरा फोन 24/7 चालू है, व्हाट्सएप पे मुझे तुरंत मार दीजिएगा, आपको कुछ भी हेल्प चाहिए तो।
आपण सगळे
आप ध्यान रखिए, आपको खाने वाने का कुछ होगा तो मेरे को बता दीजिएगा, मैं घर से बनवा के ले आऊंगा सर। घर में मम्मी है, मैं बनवा के घर से ले आऊंगा खाना अगर चाहिए।
असं डिस्टर्ब करतोय.
ठीक है सर। ओके सर, ध्यान रखिए। ओके।
झालं का? दीपक मोठांचं झालं असेल तर आपण ही मीटिंग कंटिन्यू करू. येस.
so the exogenous exogenous eczema, as I was talking about, what is difference between allergic contact dermatitis and irritant contact dermatitis? So most of the times we don't know the difference. So irritant contact dermatitis, here immunity is not involved at all. There is direct damage of the skin with the allergens like acids, alkalis, or some chemical extracts. Whereas in allergic contact dermatitis, type 4 delayed hypersensitivity is involved. And the allergic contact dermatitis, as you can see here in figure, that allergic contact dermatitis can extend beyond the point of contact. And allergic contact requires develop. Like a farmer who is working for years together, say 15 years, 20 years, slowly the parthenium, the molecules they keep on depositing in the skin, they get entry into the skin, and the allergy, the hypersensitivity, it develops over the years. And after after that much time, the allergic contact they onset the condition. But irritant contact dermatitis, it happens in minutes to hours. And the irritant contact dermatitis depends on the concentration of the responsible chemical, whereas allergic contact dermatitis, very small amounts can also trigger the reaction. So there are different variants of endogenous eczemas like discoid nummular eczema. Nummular means coin-like. So coin-shaped, it is very itchy plaque with well-defined margins, and it is common in adults because as the atopic dermatitis it shifts into adulthood, tries to limit itself. Then astiotic or eczema crackle. This is associated with severe lipid depletion as individual becomes older. The sebum content of the skin decreases, and there is a dryness of the skin, which gives crazy paving or the cracked porcelain or dried riverbed pattern, mostly over lower legs. And another variant is stasis dermatitis. It is due to the venous insufficiency, and it is associated with edema, varicose veins, and there is hemosiderin deposition, which gives this brownish color appearance. The seborrheic dermatitis, it is not due to allergy to any antigen, but as you can see here, the seborrheic dermatitis, it is limited to the hairy areas and where there are a lot of sebaceous glands like this nasolabial fold and chest area. This is the body's immunity's reaction to the normal fungus, Pityrosporum ovale. So it is commensal, but in some individuals, the immunity tries to respond against this organism which is commensal and which causes erythema. So this is different type of variant. So what happens when there is breach in the barrier? We have discussed that most of the people with this damaged skin barrier, there is more than 90% of colonization in such type of patients, and they cause itchy yellowish crust. There may be weeping, pustules, and folliculitis. And we do not treat this condition in time, this infection may travel downwards, causing cellulitis also. Another super infection in the form of herpes simplex virus. It is considered as medical emergency where there are multiple clustered vesicles and which rupture to give out punched out erosions. They may also cause fever and similar eczema. The responsible agent Coxsackie virus, which is also known as hand, foot, mouth disease, but here in these atopic individuals, this may be generalized and not only limited to hand and foot. So here in viral infections, we have to give prompt antiviral. And it's dreadful disease because if eczema herpeticum, if it involves eyes, it may cause keratitis and permanent blindness. So it is considered to be emergency treatment. So now coming to management. Here I want to mention that the foundation of treatment is repairing the barrier. As we have seen that the main problem is with the lipid barrier. So the barrier is provided in the form of complete emollient therapy from head to toe. We have to apply the emollients. The creams, they are thicker. Emollients mean like white petroleum jelly or liquid paraffin or other moisturizing creams we have to apply. So we should not consider these moisturizers as cosmetic creams, but they are actual main line of treatment. We have to provide soap substitutes. The soaps are mostly alkaline, so they also may contribute to the damage of the barrier. We have to avoid the triggers, like we should not use very hot water. Water should be used below 32 degrees of centigrade. We use lukewarm bathing. Even if the patient bathes for more than 5 minutes, it may also cause dryness of skin. So that means antigens only are not sufficient triggers, but water also can cause dryness. So if stage the eczema is not controlled by this step, we have to progress further, escalate our therapy in the form of anti-inflammatory treatment. So we can here introduce mild to moderate topical corticosteroids. Here the topical corticosteroids we are using to subside the inflammation. So acute episode we are going to control with the corticosteroids. And once the acute episode is controlled within 5 to 7 days, we have to shift to the topical calcineurin inhibitors in the form of imecrolimus and tacrolimus. Also, we don't use topical corticosteroids over sensitive areas where the skin is thin, like face, groins, and axillae. And also, we don't use these topical steroids in case of infants. We have to use that judiciously. Here, I want to remind you that we should not do loose talking with our patient that steroids are dangerous, because if they are used judiciously, if we know how to use, they are like weapons. When we are holding in a gun, we can decide whether we have to use it as protection or if we can use it for doing crime. So that is the physician's perspective. If we learn to use it properly, then they are um, like a boom. So moderate flares we can use this. If still the flare is not controlled, we can use potent topical steroids. There is called wet wrap therapy. So here the wet dressings are kept over the lesion so that the moisture is maintained. Another benefit is that patient is not able to scratch due to the dressings. So the healing is rapid. And as along with the steroid, the bleach baths, they help in reducing the bacterial load. So in severe flares, this bleach baths, which is the chemical is sodium hypochlorite, can be also used. So still, in case of refractory cases, systemic therapies like systemic immunosuppressants like cyclosporin, methotrexate, advanced biologicals, these are the newer drugs which target the interleukins which I mentioned earlier, 4, 15, 31 interleukins, they are inhibited, and the JAK inhibitors, these are the recent treatments, as well as ultraviolet B phototherapy, which is also very useful and safe even in case of children and pregnant female. So the foundation is complete emollient therapy. We have to apply this emollient creams, lotions generously, and the direction of application should be along the direction of hairs. In case of jar, we should not use fingers because already there is 90% colonization of staphylococci in patient's fingers. So we can use spatula or spoon. We have to apply emollient first and then apply topical steroid on the affected area. And the bathing water temperature should be lukewarm, more than 31 degrees centigrade. The soap, we should not be stronger soaps or body washes. Nowadays, the Syndet bars which have pH around 5.5, less than 5.5, they are recommended. So how we can manage the flare? So here, first 7 days, we use moderate to potent steroids once or twice daily to rapidly control the inflammation and to avoid the thinning of the skin. If we keep on using it uninhibitedly, there may be thinning of the skin. So to prevent that, we use weekend regime. So for maintenance, we use these topical steroids on Saturday and Sunday or weekends. And other 5 days, we go for tacrolimus, which are topical calcineurin inhibitors, or they are also called steroid sparing drugs. So understanding this is very important. So how to use steroids? So the unit is called fingertip unit. So the tip of finger, one tip of finger is sufficient to apply as equal area as that of our palm. So palmचा जेवढा एरिया आहे तेवढ्या एरियावर ते फिंगर टिपला जेवढं क्रीम येणार तेवढं त्याला सफिशियंट असेल. नीड टू अंडरस्टँड दॅट. So these are different finger tubes which we can use. So over, for example, over the lower extremity, one leg and one foot, 3 fingertip units are required. So that is the proportion. So we have seen that when the patient is not improving, even after 2 weeks of therapy, patient is not able, we are not able to differentiate between the psoriasis, eczema, and other conditions, though they are points of referral. So dermatologists have phototherapy, systemic immunosuppressants, and now the targeted biologicals like dupilumab and JAK inhibitors. So these are the points where diagnostic uncertainty is there. The patient may be required to do patch testing or biopsy to diagnose the condition. When there is suspected eczema herpeticum or urgent ophthalmology review is needed, and severe eczema in case of infant less than 12 month old or signs of failure to thrive, and disease is refractory to 2 weeks of optimized compliant topical therapy, then we have to refer the patient to specialist. So the pathogenesis involves barrier defense. The bricks and mortars are at defect. So complete emollient therapy, soap substitutes, and lukewarm bathing is recommended. The trigger mitigation, we have to minimize localized heating, treating this sweat may also initiate itching, so we have to take care of the sweat, and avoiding known contact allergens, irritants, and managing stress. The stress is also important part. So inflammation control, it is done by using topical steroids and topical calcineurin inhibitors. We have learned about fingertip unit, and complication management. We have to think of treating these bacterial and viral infections. So effective eczema management bridges the gap between repairing the barrier defect and modulating the hyperactive immune response. Consistent everyday management defeats the flare. So I wanted to make a few remarks regarding the presentation. Here, Vishali should have added history. As we know that allergic contact dermatitis, we don't call it eczema as a disease, it is a type of presentation. So in history, we should add history of atopy, like we should ask patient regarding the history of allergy, asthma, rhinitis, dry skin in his family as well as in his past. So again, asking the professional history, which profession he belongs, like a cement worker, the paint worker, the farmer, then we can suspect the allergens. While examination, the photo was shown, but only looking at the photo, it might not be clear. We have other parts like face, the elbows, because the distribution of lesion is very important. There is flexor involvement or there is extensor involvement. That pattern is also helpful in diagnosing the conditions. So in investigation, we can add simple investigation like complete blood count, where we can see whether the eosinophils are raised, whether the IgE, which is marker for allergy, is also raised. Then we can think of doing patch test. And treatment part we have discussed. Here I also want to analyze or discuss one thing, that the terminology. As we know that as science develops, there is discovery of newer things. So newer terminology is kept. So in past days, what happened? We diagnose disease only with the presentation. Whatever we are examining the patient, out of that we try to name the disease. But as the science is progressing, new discoveries are there. We are able to identify what actually is going on there. So this new generation students to try to know the etiology, and then we can target treatment accordingly. Another thing, there is one request that we should avoid the vague terms like there is heat in your body. So this may be the misnomers, because there may be different concept for different conditions, and the pathogenesis behind that is not correlated with only one word for all the diseases. So as students come to know regarding the etiopathogenesis, we can evolve more and more nice vocabulary for teaching the patient and making them aware of the conditions. So once again, congratulations, Dr. Rishali, for her presentation, and thank you, Dr. Gitanjali Madam, for giving me opportunity to present this case. Thank you very much.
Thank you so much, Dr. Ajay. You have presented a case and pathogenesis and all aspect of this case in detailed manner. And what I like most is that cycle, and that we should try to break that cycle, and it will be
Which and scratch cycle.
yeah. So thank you so much, sir. Please stay with us. Now we have Dr. Santosh Ranade with us to discuss the same case in homeopathic view. Dr. Santosh, please unmute. Yeah.
Am I audible? Am I
Yes,
audible?
yes, sir.
I'm
So
trying to.
may I share your screen?
Is it visible?
Yes, sir. Visible. Yeah.
Just one second.
Perfect.
Good evening, everyone. Nice presentation from Dr. Rushali and Dr. Ajay sir. Really hats off to you. With the patients you had described the eczema, that same patience is essential for the treating the eczema also. My way that how as an homeopath we look at the eczema. Basically, homeopathy is a little different science from the modern medicine. So, in short, I will explain you what does the homeopathy means and how it works. It's a vital force is our core concept. We compare it with the homeostasis. Our physiology book tells about us about homeostasis. Body's tendency to keep internal environment near constant. There is one nice formula given in Guyton's book, that is gain is equal to correction divided by error. Now, what we call is a homeopathic similimum, homeopathic remedy, is that remedy which gives us maximum gain. We call it as a similimum. Now, coming back to the topic of eczema, we look at eczema as a disturbance of immune homeostasis. Ajay sir had nicely explained this, how barrier breakdown, how T lymphocyte comes in, how pruritus, scratch cycle, and dysregulation of tolerance, the types of eczema. So I will not waste the time on that. I will straight away come to my topic, that how homeopathy looks towards the eczema. What as an homeopath we look in eczema is one nice book I am going to show you, is that the time of the remedy and moon phases by Dr. C.M. Bogar. Now, one characteristic symptoms is essential in homeopathy. Ajay sir, in your modern medicine, you look at the diagnostic symptoms. But homeopathy prescription is not based on diagnostic symptom, but it is based on a very typical characteristic or very individualized symptom or that present in that own case. And in many cases of eczema, one thing I find in my 20 years of practice is that the eczema changes itching with moon feathers, and that makes it very characteristic and applicable modality or applicable symptom where you can select the homeopathic remedy for the eczema. For that, I refer this book of Dr. C.M. Bogar, where different remedies are discussed with different variety of moon phases. So the way the eczema behave, we really don't know that what is the exact culprit of eczema causing itching increase with the moon feathers. It might be some immunological mechanisms in our repertory. You people can call it as an indexing, or we call it as a repertory or guidebook. You can say that many symptoms we take collect it from the repertory. Moon full aggravate skin, moon increasing aggravate. There are different remedies. Moon then full moon ameliorate. There is a different remedies. Discharges increases with moon phases. Increasing moon, there are different remedies. You can, I hope you can see my slide. They are giving the list of the remedies. So each and every minute symptom which changes with the moon phases, you can see that the symptom you can select the remedy, and this characteristic symptom make homeopath to prescribe better in eczema. Also with other modalities like the relation of eczema with menses. In especially in female patient, eczema got variation with the menstrual phase. As estrogen got soothing effect, and progesterone got bad effect on the eczema. That's why you with the phases of the menstrual cycle, there is a variation in eczema, and that is also the prescriptive background or prescriptive base of the successful homeopathic prescription in the field of eczema. Now, in moon phases, so whether it affect our body or not, one of the common experience is the idiopathic edema of female, which is present on upper part of body, which variate with menstrual cycle and it variate with the moon phases also. So, but being a physiology teacher, I will tell you honestly that there is not yet any pathophysiological or medicinal basis for the process which we are seeing commonly. You people can also look and verify this observation. So we are doing one small observational study in our clinic and our college, that with related with how the moon phases affecting the eczema. For that we are doing this scoring system, total Ig levels and peripheral eosinophil count and sleep quality. We are keep up these 4 parameters, and we are assessing these 4 parameters with the new moon, first quarter, full moon, and the next quarter. And we want to establish what the observation is there in homeopathy and in clinical practice in homeopathy, which is giving us tremendous good results. And how, what could be the actual basic scientific basis? As it is, I'm telling again, it is not yet proved in physiological or pathological way. We people are working on that part also, but it is working in as part of the clinical part. And homeopathy believes in that way. It work. And with clinical, as a clinical homeopath, we had used many in many cases this moon phases modalities. Now, on the basis of areas affected, homeopathic remedy changes. So for scalp, sorinum, mesorinum, graphitis. For eyelids, no, this you can see the diagram here. This is not the generalized way of prescription in homeopathy. Homeopathy being a holistic science, it work on the idea of mind-body relationship, mind-body interaction. So the mind and body and all the symptoms. So alone, I am not promoting the prescribing remedy on the basis of areas affected. But yes, these are the way you can confirm your remedies. Each remedy has its sphere of action. Especially, I work a lot in skin cases that when patient got varicose veins, and because of there is a arthrostatic eczema or the patient's leg is edematous and arthrostatic edema, as a homeopath we are doing so good that the veins start draining and the edema reduces and the eczema improves. Now, there are other ways also you can prescribe, like where the scalp, and the homeopathy is based on the symptoms. So subtle or small symptoms, small modalities, aggravation, amelioration factors, especially the food. And one more area where homeopathy work is your bowel. Nowadays, as Dr. R.D. Lele sir in his book of clinical science and research call the skin as neuropsycho-endo-immuno organ. So the eczema or the all the skin diseases, psoriasis, eczema, that have multiple origins. One of the part which is recently coming up is your gut microbiota and your bowel health. Again, as an homeopath, we got bowel no source to correct your gut microbiota and to affect or to improve your skin conditions. And the last point I want to share it as that neuroendopsychoimmuno organ skin, your mind plays lots of role in the management of eczema. So for the successful prescription of homeopathic prescription, you can use this kind of modalities as well as mental sides, as well as your gut health, that's gut microbiota, and so many things. I am again thankful to the MEH Ayush department, MEHS Nashik, for giving me opportunity, and I hope you had given time from 5:30. I will stop over here. I will not exceed your time limit, and I'm very happy to listen the different approaches. And I'm again thankful to the department, Ayush department, Gitanjali madam, and all your team, and thankful to all listeners for during my 5 minutes lecture. You keep all your mic muted. Well, thank you once again for all.
Thank you so much, Santosh sir. So modalities are important in homeopathic aspects, and gut health is also important. So there is micro and micro thinking about all the patterns of behavior and signs and symptoms. Thank you so much, sir. So next expert is from Ayurveda, Dr. Rohan Deshpande. Okay, I think he is not with us. So is there any question from audience? आता कोणीच बोलणार नाही. हा, काही क्वेश्चन्स आहेत का ऑडियन्स कडनं किंवा डॉक्टर वृषाली?
नो मॅम.
ओके, पण तुम्हाला काही सरांनी सजेशन सांगितले, तुम्ही नोट डाऊन केले?
येस मॅम, आय हॅव
हा.
नोटेड.
ऑफ ॲलर्जी किंवा त्यांचं प्रोफेशन हे तुम्ही विचारायला पाहिजे. तुमचा जी केस होती त्याचं काय प्रोफेशन होतं?
मॅम, ही वॉज अ ऑफिस वर्कर.
अच्छा, ऑफिस वर्कर. ओके. तर मग अजून जर कोणाला काही क्वेरीज नसतील तर आपण इथे थांबूयात. थँक्यू सो मच अगेन अँड अगेन, डॉक्टर वृषाली, डॉक्टर अजय सर, डॉक्टर संतोष सर. Thank you so much. We will meet again. So next series is gynecological disorder. So please be with us for gynecological disorders. Thank you.
Thank you, ma'am.
Thank you.